Animal bite and sting might seem like minor injuries at first, but it can quickly become life-threatening without proper treatment. The question is, what can we do to protect ourselves? Join us here to discuss further on life-saving strategies for venomous animal bite and sting from pre-hospital care to emergency center.
Okay, very good morning. First of all, I would like to welcome everyone to today's program of CPC. So I would like to introduce our speakers for this morning. The first one is Dr. Nur Safiahani Mayunin from our emergency department. She's our currently Master's Emergency Medicine candidate. And our second speaker will be Dr. Vigneshwaran Govindasamy from the Orthopedics Department, okay, who is also Masters. Yes, okay. So we have our Masters candidates here this morning. And finally, I will do the summary of the case that we will discuss this morning. So without further delay, I would like to invite Dr. Safiahani to start the ball rolling. And she will be asking questions. So please respond. If you don't know, also please respond. Okay, so that we can have a bit more interactive session this morning. Okay, so we'd like to start with Dr. Safia.
Okay, thank you, Prof. Khaldun, for the introduction. So my name is Safia. I am from Emergency Department. So I'll be presenting the first half of the case on an integrated approach in managing a snake bite. Okay, this will be an interactive session, so hopefully can get your involvement as well. Okay, starting off, Sunday late afternoon, we received a 32-year-old construction worker in ED. So the main complaint was that he was bitten by an unidentified snake on the left foot at around 5:30 p.m. at his workplace at the construction site. So basically, he was walking on a soil path towards the canteen when a black snake emerged out from a pile of crates and bit him on the dorsum of his left foot. So immediately post being bitten by the snake, he complained of pain. Initial pain score at that time was 2 out of 10. So what the co-workers did at that time, they applied 2 tourniquets above the bitten site and brought him to our department roughly 1 hour later. Okay. So he arrived to us 1 hour and 10 minutes later at around 6:40 p.m. So when he came in, he was immediately pushed to recess. He was drowsy, cold and clammy, and was sweating profusely. Vital signs at that time, blood pressure of 105/79, heart rate 69, respiratory rate of 18, oxygen saturation of 97, and a pain score of 10. So severe pain. Examination, systemic examination, cardiovascular, noted that he had poor pulse volume with cold, clammy hands. Otherwise, the respiratory and GI system were unremarkable. Neurology was also unremarkable. Pupils were equal and reactive bilaterally. There was no ptosis. There was no external ophthalmoplegia. And this is his foot. Okay, anyone would like to describe the foot finding here? There's a mic over there. Anyone? Okay, so no one is answering. So you can see what it says? Yeah, there's an embedded broken off fang on the foot. So we dried up, we removed the fang, we cleaned up the wound, and this is what we saw. So what is this? Sorry. Louder? Bruise. Any other medical term that you would like to use? Loud? Sorry, I can't hear you guys. There's a mic over there if someone wants to go there. So what is this skin discoloration called, specifically for snake bite? Okay, so it's called dermonecrosis, which later we will discuss further lah. Okay, so at this point of time, you got a young gentleman, no comorbids, bitten by a snake, presented to you, sweating, drowsy, BP, borderline. What's your initial impression at that time? Your differential diagnosis. What will be highest on your list of differentials? Pain score of 10, drowsy, sweating, was just bitten by a snake 1 hour earlier. So snake bite, you always need to look for symptoms, signs and symptoms of envenomation. So the first higher up in your differentials would be, anyone? No? Okay, so pain score was 10. He was profusely sweating, blood pressure was borderline. So the first thing that comes in our mind, is vasovagal attack because of the pain lah. So this is not specifically to the snake, as in it's not an envenomation symptom, but it's because of the pain. Okay, pain can cause vasovagal attack. So specifically to envenomation, what can you get? What system can be involved? So you can get neurotoxic. So that's why in your history taking, your physical examination, you would want to look for ptosis, external ophthalmoplegia, eye symptoms, neurological symptoms. So this patient was drowsy, was just bitten by a snake. Could it be a neurotoxic envenomation? Okay. So your third differential, again, envenomation could also cause hematotoxic envenomation. So bleeding tendency, blood loss, leading to hemorrhagic shock, leading to the borderline blood pressure, the drowsiness, could explain that. Understand? Okay, so the fourth differential, drowsy, bitten by a snake, the patient could have some sort of arrhythmia causing cardiotoxic envenomation. That's the arrhythmia causing poor cardiac output, that's the borderline BP, that's the drowsiness. Okay, so you need always to correlate with the clinical findings. So at that point of time, the treating team treated him as per unidentified snake bite with anaphylaxis reaction. Okay, show of hands, who agrees with the diagnosis? Hands up, hands up. No, no hands? Everyone disagrees? Who disagrees? Higher, higher, higher. Who disagrees with the diagnosis? Are you still sleeping? Wake up, people. Okay, agree? Agree, hands up. Hands up. Disagree? Okay, care to explain why you disagree? Why you agree? Sorry? There's a mic over there. Shout out your answer.
The presentation wouldn't fix an anaphylaxis reaction, such as like swelling, or there would be rashes, there would be bronchospasm. Or
Was
such.
there bronchospasm?
There wasn't just now. But I think the presentation of this patient does not fit the anaphylaxis.
It does not fit. Okay, correct. So on that line of anaphylaxis reaction, the patient was given IM adrenaline, 1 milligram, a total of ×2. For the pain score of 10, he was given IV morphine, wasn't sufficient, so he was given a top-up dose of fentanyl 50 and another 50. He was a foreigner, so the tetanus status, vaccination status was unknown, so he was given a ATT injection as well. For the foot itself, as mentioned earlier, we removed the foreign body, irrigated the wound, and immobilized the affected limb lah. Okay, so investigation, what would you like to order? So clinical examination, physical examination, history taking, physical examination, you've come up with a list of differentials. What would you like to do now? What would you like to order in terms of investigation? Okay, so basically you want to take investigation to rule out your differentials lah, to rule in or rule out your differentials. So, cardiotoxic, you would want your ECG. Hematotoxic, you would want your FBC coagulation profile. Neurotoxic is mostly clinical. Okay, so ECG was normal. Investigation was essentially unremarkable. Total white of 14, HP was normal, platelet was okay, coagulation profile was also normal. CK was also normal, 221. Okay, so from the history, examination, now you've got your investigation. What else would you like to dig in further? Okay, so you would like to identify the type of snake that bite the patient to narrow down your diagnosis. Okay? So, co-workers came back to you. They took a video of a snake that was found nearby the incident site.
Ini masa hari-hari bos. Hari kerja ni saja. Aku ada latih dulu tadi. Ini panjang bukan panjang.
Okay. Anyone would like to describe the snake? Black, yes. What else? Besides being black? What about the nature of the neck, the head? Okay, any guesses of the specific species of the snake? Cobra. Okay, good.
Ini masa hari-hari bos. Hari kerja ni.
So REX, Remote Envenomation Consult Service, was consulted, and the diagnosis is there's dermonecrosis, cobra, possible cobra snake bite. What's your diagnosis then? You've got all these information so far. So could you narrow down your diagnosis at this point of time? So possible white snake, cobra, snake bite with what type of envenomation do you think the patient has? Any systemic envenomation? No. So local, there's cytotoxic lah. Because at the foot itself, there's dermonecrosis, which is a pathognomonic of cobra snake bite. Okay, so we've identified the snake bite. So we need to closely do a serial monitoring involving your rate of proximal progression, your pain score, your vital signs, and your lymph nodes lah, involvement hourly, and do 6-hourly blood investigation. Okay, so this was his hourly vital sign, RPP, PSP, and lymph node charting. So nothing too significant apart at 7:55 a.m. the RPP went up to 9. Reliable or not is another question lah. Okay, blood investigation done 6-hourly. Again, normal. So further progress at 6 hours since he was bitten by the snake, noted there was expansion of the dermonecrosis with progressive swelling proximally. So REX was consulted and decision was for antivenom. NKAV, Najakuti antivenom, a total of 10 vials was given. Post the NKAV, the patient developed chills with a recorded temperature of 37.6, for which tab paracetamol was given lah. The patient was then referred to medical team for continuation of care. Okay, so in medical ward, what happened? 12 hours post-incident, noted the patient started to spike some temperature with worsening of the dermonecrosis and proximal swelling. Distal circulation was otherwise intact. So your concern now is possible secondary bacterial infection. So that's why you started the patient on antibiotic. So initially was started on IV augmentin, but the patient still continued to spike temperature, which was then escalated to IV unacin for a broader coverage. So on day 2, Worsening again, swelling, redness, now progress up to the mid-shin, but the new finding now, there's skip lesion. There's dermonecrosis skip lesion. Investigation-wise, you can see that there's an increase in total white, increase in CRP, and increase in the CK level as well. Okay, so on day 3, the patient was referred to orthopedic team lah. The question at that time, so the secondary bacterial infection, could it also be compartment syndrome? Who thinks this is compartment syndrome? Okay, this part, Vignesh will present in a bit later lah. Okay, so we'll go through in a ED perspective first. So, how do you manage an unidentified snake bite in ED? So first, you need to know the type of snake lah. So in Malaysia, there's 3 venomous snake families in Malaysia. They are Elapidae, so your cobra, your Viperidae, your pit viper, and your Natrichidae. Remember, not all bites by these venomous snake will result in envenomation. So that's why you need to look out for the systemic and the local envenomation symptoms. As mentioned earlier, dermonecrosis is a pathognomonic of cobra venom cytotoxic effect lah. As our patient just now, we treated him for anaphylaxis, but in real life, anaphylaxis from a snake venom is very rare. So, adrenaline is not the standard care lah, for these cases. Always look out for possible envenomation effects. So, your local could be your cytotoxic, the dermonecrosis, worsening progression, versus your systemic lah, could either be neurotoxic, hematotoxic, cardiotoxic lah. Okay, so if you don't know the snake bite, you can always refer to this lah, which is freely available. Okay, so in Malaysia, cobra, there's 2 types. The picture already came here lah. So there's Najah kutia and there's also Najah sumatrana. Okay. Importantly, if you cannot identify the exact snake, then you can narrow down your differential possible snake based on the locality. So Najah sumatrana, Najah sumatrana, more common in the southern part in Johor, while Najah kutia, you can see it in Selangor, KL area and the northern up here lah. Okay. So, once you've identified the snake, then you would always need to look out for possible envenomation side effects lah. So the 2 snake bites as mentioned earlier, your Najah sumatrana and your Najah kutia. So the important component of the venoms, there's 4. The first one is your 3-finger toxin. Then there's your phospholipase A2. There's your metalloprotease. And there's your hyaluronidase. Okay, in terms of envenoming side effect, so you can get your local and your systemic. So local wise, like our patient just now, he had pain, cytotoxicity, tissue necrosis. And specifically for Najah sumatrana, it's called a spitting cobra. It's called spitting cobra. So they tend to spit their venom into the eyes, which will result in venom ophthalmia. Systemically wise, you need to look out for your neurotoxic, so it can cause neuromuscular paralysis and also cardiac envenomation. Hematotoxic envenomation is not common in cobra envenomation. Okay, any questions from the floor? Okay, if no question, then I'll pass the floor to Dr. Vignesh from Ortho to present the second half of the case.
Hello, good morning everyone. Okay, I'm Dr. Vignesh from the orthopedic department. So I will move on to my part. So this case was actually referred to us on the day 3 when patient was admitted in the medical ward. So actually they referred to us to rule out compartment syndrome of the left foot, right? So upon our examination, patient was alert, conscious, the vital signs were stable, patient was afebrile at the time and the pain score was 3 out of 10 at rest. At this time, patient already on IV analgesics. And local examination of the left lower limb, as you can see in this picture, there is swelling and redness up to the mid-shin level. minimal tender at the foot region. It was soft, no crepitus, dermonecrosis with pus discharge, and the distal pulses were felt. CRT was less than 2 seconds all toes, and the passive stretch of all toes were negative. So at this point, we actually were ruling out compartment syndrome. So from anyone from the floor, can anyone tell what is the first sign of compartment syndrome? Sorry? Excellent. Okay, right. So excruciating pain despite on analgesics, yeah? Right, at this time, pain score already 3 on analgesics, okay? So this was the X-ray was taken. So from the findings, there is no gas shadow, no foreign bodies were found, and there's no osteomyelitis changes, okay? So the diagnosis given was unidentified snake bite and venomation, probably from the Naja species. And from our side, it was an infected wound dorsum aspect of the left foot, secondary to snake bite and venomation, unlikely compartment syndrome, and also at the same time, it was unlikely necrotizing fasciitis. So in necrotizing fasciitis, what you can see in the X-ray? Very good. Okay, so in this X-ray, there's no gastrula was found, and also there's no crepitus was felt upon palpation. Okay. So at this point, what is your plan? Can anyone from the floor can tell? We have already ruled out compartment. We already ruled out necrotizing fasciitis, and now we are treating him for infected wound. So what is the next step in the management? Okay, so at this point, we still continue the IV antibiotics, which is IV Unacin, and then we proceeded with wound debridement of the left foot, which was performed on the day 5 of admission. And intraoperatively, there was liquefactive necrosis of the subcutaneous tissue over the anterolateral aspect of the left ankle, extending to dorsum of his forefoot. And unhealthy tissue was debrided, and about 50 cc pus was drained. Tissue culture and sensitivity was sent intraoperatively. We must send a tissue culture and sensitivity if there is an infected wound, okay, so that we can treat accordingly once the culture result is out. All right, so this was the wound condition after the day 1 post debridement. This was the wound inspection. So you can see the wound was nicely debrided. However, there is a minimal slough here and there. Is there? It's okay, don't worry, we will continue with the dressing in the ward, yeah? So he was transferred to orthopedic ward subsequently for wound management and antibiotic therapy, which was IV Unacin. And he underwent daily dressing with hydroxine solution and Bactigras, and followed by 3 cycles of vacuum-assisted closure dressing with repeated tissue culture. So the first image here is the hydroxine solution. So have you all seen in the ward? Yes, okay. And next is the Bactigras, and third one is the vacuum-assisted closure. So this is the modern dressing which is widely being used now, especially for a very large wound. It drains all the exudates and promote granulation and for faster healing, and also prepare the wound bed for next step, which is skin grafting, right? So can anyone in the floor can tell what do you think the common organism for cobra bite and venomation? Anyone? Okay, no one. All right. So, okay, no problem. So Enterococcus species and Morganella morgani are the most encountered organism following cobra bite and venomation. So this, according to the paper in 2022 by Lin and Shung. All right, so as per expected, intraoperative cultures grew Morganella morgani sensitive to cefepime, and antibiotic therapy was changed accordingly on day 5 post debridement, which was IV cefepime 2 gram twice daily. All right, so this is the wound progression, as you can see, from the day of admission till day 27. So this is the pre-skin grafting. So this is day 3, day 6, day 10, day 16, day 20, day 23, day 25, and finally day 27, which shows very good granulation, is free from infection. There is no obvious exudates noted, there's no slough. So the wound bed is ready for skin grafting. So for this patient, we actually plan for a skin grafting. Okay. A little bit on the skin grafting. A split thickness skin graft can be safely performed when the following conditions are met. Okay, first, wound bed condition, and second is the patient factors. So in the wound bed conditions, you must have a good vascular supply. The recipient side must have an adequate blood flow, example, healthy granulation tissue, muscle or periosteum, and there is no active infection must be there. Infection must be controlled before grafting, as bacteria can cause graft failure, and should not have excessive exudate, as heavy drainage can prevent from the graft adherence. So the graft cannot adhere to the recipient side properly. Yeah. So next is the patient factors. Patient must be hemodynamically stable. So they should have stable vital signs, and they must have a controlled comorbidities such as diabetes, peripheral vascular disease, and immunosuppression should be managed in the ward prior to the skin grafting. If let's say the patient is having uncontrolled diabetes, please control so that you have a good outcome later. And last is the inadequate nutrition. Protein levels should be support the healing. So always check the albumin level in the ward. Okay. So this is how we do the skin grafting. So this is the image showing the ipsilateral thigh of the patient, the same side. So the graft was harvested using a pneumatic dermatome. That's the instrument that we use in the operating room, with an appropriately sized donor graft taken from the ipsilateral upper thigh. And the medium thickness skin graft was harvested, which is 0.3 mm using pneumatic dermatome. And then the preparation of the mesh skin graft is performed with the skin graft mesher. And the mesh graft was applied at the wound bed and sutured using the absorbable sutures. So this is how the meshed graft will look like. Okay. So once we are ready with the meshed graft, we will apply on the recipient side. So the first image showing the wound inspection of the recipient side, day 5. And the next picture is the wound inspection donor side on the day 10. So actually very good uptake of the graft, yeah. This one is actually performed by myself. So I'm proudly saying this, okay. All right. So this is the good uptake of the skin graft at 6 weeks. So which you can see very good complete recovery. Patient was actually very happy with the outcome, and there is no contractures noted over the ankle region. And the thigh region, it shows the well-healed wound at the donor side at 6 weeks or so. So is recovered well. So patient was discharged well following that. So a little bit of compartment syndrome and necrotizing fasciitis before I end my presentation. So compartment syndrome, you have to look for the 6 P's. First is pain. So pain out of proportion despite on analgesics, paresthesia, poikilothermia, pallor, paralysis, and pulselessness. And passive stretch will be positive because once the muscle is ischemic, so when you passively stretch affected part of the limb, patient will present with pain. And the compartment will not be soft and will be in tender. If let's say necrotizing fasciitis, patient will present with fever, tachycardia, hypotension because of systemic involvement, and the skin will be discolored with dusky, purplish or necrotic patches, and usually they will present with crepitus upon palpation because there will be gas forming under the skin. It will be suggested by Clostridium infection. And also there will be some bullae, hemorrhagic blisters, and skin necrosis. And you can smell the foul-smelling dishwater discharge like fish smell discharge. So this is how we differentiate from necrotizing fasciitis and also diabetic foot ulcer. All right, thank you so much. And moving on to Prof. here.
Okay, so as you can see just now, how simple so-called snake bite can last for almost a month of management, and this does not end in the emergency department or in medical ward. Okay, so it involves other expertise in terms of the managing in the acute stage and then of course the recovery stage, and also maybe there is occupational therapy required for this patient. So let me give you a bit of general overview of why this case is very important to be known by medical students. For me, my motivation is this. This is my mentor, Professor Ted Horbosa. He is currently the health minister of the Philippines. He told me once that be a patient's advocate. If we are doing it for the sake of ourselves, there is no guarantee we will win. But if we fight for our patients, we will always win. So this is always my motto in in the emergency department. We're not doing it for our sake, but we're doing things which is going to be beneficial for patients. And we fight for patients' right. Okay. So what is remote envenomation consultancy services? So this service is actually a risk management system which I developed in 2012. At the time, I was only me, but after that, we grew with the other emergency physicians around the country. So what we did was, what we do is we provide consultation service for young doctors, for inexperienced doctors managing cases of envenomation or poisoning related to natural toxins. So we have been recognized by the Malaysian Society of Toxinology and also the Ministry of Health, and you can contact us via WhatsApp in your hospital's group. So each hospital in Malaysia have a REX group where if you have a case, you can present the case, and everybody else in the group will also learn how to manage the case better. Okay, and the whole idea is to get a favorable outcome. As you can see from this patient, the patient received the appropriate antivenom, the patient received the appropriate diagnosis, so that we can manage the patient much better and also closely monitored. So REX has been involved with this case for the whole time, since the arrival until the patient was discharged and followed up. So it's not just at one point of contact. If let's say you call Poison Center, you just call them for information and that's it, finished. But REX will follow up the patient throughout the patient's stay and management. So how famous are we? Or how popular are we? So as you can see over the years, the consultation number has increased. We are now looking at between 1,000 to 1,200 cases per year. And majority of the case, as you can see there in the red line, is snake-related injuries. Okay, related injuries doesn't mean just bite, but also, as Dr. Kashid, there's a spray to the eye, venom ophthalmia, and some patients were bitten and entangled or strangled by python as well. So we had few cases of death by python strangulation. So majority, as you can see, are Malaysian, but non-Malaysian makes a big portion of our patients that we see, because as in this case is a foreign worker. So we have a lot of workers, in contact with nature, either in plantation or in construction and so on and so forth. So we have to cater for them as well. So this has some implication for health expenditure in our country. So that's why we are very, very, adamant that some insurance coverage needs to be provided by employers for their employees. Yeah? So other parts of the body that is bitten are not just the leg. We see them in the hands. Upper limb is the most common, second common after lower limb. And some even bitten on the trunk, on the head, and also what we call in the face area. So just recently we had a case, someone bitten on the lips, okay? So the whole face swollen up. So that was kind of terrifying because, what will be affected? What is your worry if somebody bitten in the face or oral cavity? The airway, yeah, the airway. So that's the most, horrifying thing to see. So the top 5 venomous snake that we see causing bites in Malaysia are from this cobra species. And as mentioned, we have 2 species of cobra, Naja sumatrana and Naja cautia. And then we have the pit vipers. So depending on where you are in Malaysia, the pit vipers are not present everywhere. So some states has them, some states don't have this species. If you go to Sabah and Sarawak, there will be different species of pit viper. So snakebite in Malaysia is very complex. It's not one snake, and it's not snakes is present everywhere, same species. So that's where the knowledge about the snake species is important, and we come up with that book, little book, e-book, Land Snake of Medical Significance in Malaysia. It's already in the 3rd edition, and everybody here has it, okay? You have access to it. So in terms of diagnosis, as you see just now, we have somebody took a picture, a video of the snake. Do you know what species of the snake is that? Any idea? Species name. Naja cautia. So that was Naja cautia, and it is present in KL. We know that. Even in HUKM, we've encountered a few. But we cannot use that as the reason to confirm the identity for the snake that bite the patient, because the patient did not see that snake. It was found by their friends when they go searching around the area. It can be other snakes in the area as well. So therefore, in terms of evidence, this case is actually unidentified snake bite, because we cannot get the actual snake, then the actual picture of the snake. And that video was actually taken a few days later. It's not on the day or itself, and nobody checked whether there is a fang missing or not from that. Okay, you don't go around and looking for saying, open your mouth, can we see if your fang is still there or not? No, we don't do that. Okay, so that's the reason why. Okay, so this is the very important step for you to take when managing snake bite, is to do this observation.
As you can see, this is a snakebite monitoring chart that we use. It should be performed hourly for the first 12 hours. We need to fill in the patient information and the sign and symptom present. The chart summarizes the commonly observed sign and symptom due to the snake envenomation. Monitor for the general condition of the patient. Take if the patient have drowsiness, vomiting, or abdominal pain. The sign and symptom may vary according to the different snake bite. In addition, we also need to look at the local effect that occur in the patient, such as dermonecrosis, public discoloration of the skin, or blister. Measure the size if present. Next, we examine for the neurotoxic effect, which often shown in electric bite like cobra, crate, and sea snake. This should be performed at least hourly for the first 12 hours. Firstly, ptosis. Ask the patient to look up and observe the upper eyelid. If ptosis present, upper eyelid outward movement will reduce or absent. Secondly, we observe for the external ophthalmoplegia by asking patient to follow the movement of object from patient's left to the patient's right. The affected eye unable to follow in certain direction because of the weakness of the extraocular eye muscle. Next, dilated pupil. This is a sign of envenomation of cobra, crate, coral, and sea snake. Then, broken neck sign as a result from paralysis of the neck muscle. Dysphagia or swallowing difficulty and speaking difficulty is due to the muscle paralysis. Last neurotoxic effect that needs to be monitored is breathing abnormality with a poor respiratory effort due to the paralysis of the respiratory muscle. Using the serial assessment chart, we also need to document any hematotoxic effect and rhabdomyolysis sign. From the inspection of the wound, we document if there is a bleeding from the bite side. Also noted if patient complaining any other spontaneous bleeding from the nose, skin, gum bleeding, hemoptysis, hematemesis, or hematuria. Next, document rhabdomyolysis sign. Ask the patient of any generalized muscle pain and muscle tenderness on palpation. We need to monitor if any dark urine present. We can see the hematotoxic effect usually in the case of pit viper bite, while rhabdomyolysis in the sea snake bite. For the snake bite chart, we need to document GCS, blood pressure, pulse rate, respiration rate, saturation oxygen, pain score, RPP, and tender limb node. RPP or rate of proximal progression is a parameter to monitor local inflammation. It also determines progression and severity of local tissue injury, for example, necrosis, bruise, and swelling. It is obtained by determining a fixed time interval to review the progression every 2 or 3 hours. To get the reading, we measure the distance between two microportic borders, and the measurement will be documented in centimeter per hour. This is blood test documentation. 20-minute whole blood clotting test will be considered if coagulation profile is not available. White blood count may increase due to envenomation. HB will drop if there is a significant bleeding. Platelet may be decreased in victim of envenoming of vipers. For coagulation profile, PT, APTT, INR should be repeated 6 hourly for suspected pit viper cases. Creatinine kinase shows sign of acute kidney injury or renal failure, myonecrosis, and rhabdomyolysis. When coagulation profile is not available, consider doing 20 minutes whole blood clotting test. It's a quick bedside test for unidentified bite or when a pit viper bite is suspected. First step, you should place 2 ml of freshly sampled venous blood in the container. Leave undisturbed for 20 minutes, then tip the container once. If the blood has not clotted, the patient may have coagulopathy.
Okay, so just to add on a bit, if you put in a container the blood, you have to use a clean glass container, not plastic, okay? Because you need the clean glass to initiate the coagulation process. So we have a lot of efforts being done to have our guideline in Malaysia. So this is our first guideline in 2017, endorsed by KKM. So please have a read about that. And coupled with the land snake of medical significance in Malaysia, some image to assist our medical students and also doctors. So in terms of snakebite in Malaysia, we have done a lot of research and development. So one of it that we have done is looking at how we can monitor a patient from whatever snakebite closer or better. So Dr. Vignesh was saying about the identification by clinical of compartment syndrome. So we have another tool that can help that, where we can visualize the progress of patients' edema or swelling better. So this is what we call POCUS bedside, and we applied it and combined it together to become a protocol of what we call PULSE protocol. Yeah? So this one I developed with our colleagues. We developed in Malaysia, but they do the research for their cases in Taiwan. So this is what our study is about, and we are applying it now for all cases that is actually having
PULSE
snake bite.
protocol 应用焦点是照护超音波于龟壳花咬伤造成的局部组织伤害治疗
If you don't
与
understand,
评估
read the translation. Okay?
设想构思与实际执行的三军总医院急诊医学部人员。换言之，最困扰临床的问题是，此时是否产生了急性腔室症候群，血清需要施打到什么时候才足够？我们提出 PULSE protocol 来处理这些临床问题，包含3个步骤：一 localization 定位，透过超音波了解肿胀组织所在的区域；二 RPP 计算肿胀进展的速率 rate of proximal progression， 并依此数值的变化决定是否继续施打抗蛇毒血清；三 draft量测患肢受压迫的动脉都普勒波形变化，观察是否出现 diastolic retrograde arterial flow， 评估是否有发生急性腔室症候群。步骤一 localization 使用线性探头定位肿胀的位置，寻找 cobblestone sign， 如左图箭头所示。有别于传统目测，超音波可以评估肿胀区域是在筋膜内或筋膜外，组织间水肿若发生在筋膜外，则发生急性腔室症候群的机会较低。步骤二，计算肿胀进展的速率 rate of proximal progression， 找到 cobblestone sign 与正常组织的边界，并在皮肤上做记号。 固定时间间隔，依此要领标记直到肿胀停止蔓延。将两标记的距离除以时间，可以得到肿胀速率，也就是 RPP。计算 RPP 并记录下来，透过记录可以发现，尽管肿胀仍在持续，但肿胀的速率会在某个时间点下降。我们建议当观测到肿胀速率下降，即可停止施打抗蛇毒血清。步骤3，量测患肢受压迫的动脉都普勒波形变化，选取肿胀区域的动脉，比如足背动脉、桡动脉或肱动脉，找到动脉纵谱方向后，调整为都普勒模式，再使用超音波 Pulse Wave Mode 测量收缩期与舒张期波形。大部分健康成人波形都朝上，若出现反转朝下，表示此时组织压力可能已经略近于血管舒张压力，有可能发生急性腔室症候群。再次总结 Pulse Protocol 的3个步骤：1. Localization 定位，透过超音波了解肿胀组织所在的区域。2. RPP 计算肿胀进展的速率，并依照此数值的变化决定是否继续追加施打抗蛇毒血清。3. Draft 量测患肢受压迫的动脉都普勒波形变化，评估是否有发生急性腔室症候群。特别感谢台北荣总邓昭芳主。
Okay, so in terms of antivenoms, I hope you get that. You can always watch it on YouTube. So antivenom usage in Malaysia, most of it are because of the Naja species. So we use the NKAV, Naja cautia antivenom. It covers both Naja cautia and Naja sumatrana. Okay, so there is actually a way of how to prepare and give antivenom. So this is a video that we do, and you can watch the video later. Yeah. So this is my final slide. Not all snakes are venomous and dangerous to humans. Not all snake species are present, nor homogeneously distributed in all areas of the country. And knowledge of snake species is actually going to help you. And by knowing the geolocation as well, can narrow down the species of snake that might cause the injury, especially if it is the snake is not present. By just from looking at signs and symptoms, you can use these extra details to help you narrow down and also optimize your management. So detailed history, I cannot emphasize more. It is very, very important. So sometimes to the level of where the snake is when it bites the patient, what time of the day is the snake actually in the house, outside the house, in the bathroom, etc. Okay. So appropriate and timely antivenom is necessary. As you can see, this case shows that when the patient arrives, it doesn't mean that they will get antivenom. So we look at the progression and we see all the signs, symptoms, and then all this will then indicate that this patient requires antivenom. Okay. So appropriate and timely antivenom is crucial because we don't want to waste our resources. And finally, managing significant snake bite and venomation, as you can see, is lengthy process, 30 days, yeah, and we definitely transverse all the specialty that we have in our hospital. So do not be shy to ask for help from anybody, especially also with Rex. Okay, so now you know what Rex is. So these are all my other mentors, Dr. Scott Weinstein and Prof. David Worrell from Oxford, and all our collaboration in ASEAN, Rex ASEAN. Okay, thank you very much. We are now open for the floor for questions before we do our quiz. We have plenty of time here. Any questions from the floor? All three of us, maybe Dr. Winish and Dr. Shafa can come up. Ada soalan? Ada siapa sini pernah kena gigit ular? Dalam mimpi tak kira. Real life. No? Ada. Have you seen snake in UKM? HUKM? Ada? Dekat mana? Asrama? Kat atas tu? Okay. So what do you do when you see a snake? Who do you call? Jangan call Ghostbusters. Tahun depan pun tak sampai. Huh? Who do you call? 999 dekat dalam kampus tu kita tak jalan juga. Kita ada keselamatan kan. So our keselamatan. So you can call. We have actually a group, task force membenteras tikus in UKM. One of the reason why, because it can attract all the snakes in our hospital, our compound. So if we can benteras the source of where the reason for the snake to come for food, and hopefully we will reduce the risk of having snakes in our compound. So that's why we have a task force membenteras tikus in HUKM, okay, in our hospital. So another big group that will help, that if you found any of these animals, is to call. Don't do it yourself. Don't go around chasing the snakes. Okay, call our keselamatan. Very important. But when you call our keselamatan, make sure that you always observe where the snake is, because when the keselamatan arrive, they can actually follow your instruction to the source of the animal, where the animal is. If you go away and come back, and most likely the animal has gone off somewhere, and that reduces the chance of it for being rescued. Okay, so we don't kill snakes in Malaysia. We rescue snakes. So it's very contra to what our current understanding of conservation is. So we are involved with conservation as well, even though we are medical. Okay, ada soalan tak? Anything? Yes, Prof. How much is your car? Okay. Yeah, the cheapest car in Malaysia is what? Dululah. Kamu mungkin Myvi, before Myvi is ni kan, Alza. Alza, how many thousand? Axia, sorry, Axia is how many thousand? 30,000? Katalah 40,000. So one vial of that, what we call antivenom, is $150. Satu, $150. And we do not manufacture it in Malaysia. We have to import from Thailand. Okay. The reason being, we have similar species, and from our preclinical studies, it can neutralize the venom from our species as well. Okay. So one is $150. For this patient, how many vials we gave? 10. Yeah. So that's $1,500. That doesn't count all the other drugs that we use, all the care that we give, all the ICU stay, or all the surgical, all the SSG we give. So in terms of cost, it may reach up to your Axia per patient. Okay? And that's for Cobra. All right? But what about sea snake? And that's not the most expensive antivenom in Malaysia that we import. Okay? The most expensive is for sea snake. You know sea snake? Have you seen a sea snake? You go around, now people jumpa buaya dalam laut. Bukan saja ular dalam laut, buaya dalam laut. So anyway, for sea snake, the antivenom we use minimum is 1 vial, and that 1 vial, it has to be imported from Australia. Okay? For the land snakes, we import from Thailand. For the sea snake, we import from Australia, and that costs 17,000 ringgit, 1 vial. And the patient may require 3 to 5 vials as well, depending on the progression and sign symptoms. So definitely more than the Axia, if you are bitten by a sea snake. Okay? Yeah. Yes, Prof. Yes. Interesting, they just called me a few days ago, Malim Gunung, Kelantan. They are actually considered non-clinical, right? They are orang awam, biasa. So for orang awam, kita tidak ada consultation process yang kita bagi. They can call Pusat Racun Negara for information, but what they always been, orang awam disarankan is to go to the hospital as soon as possible and ask the doctor to contact REX, because it's a clinical consultation, so we don't provide it for orang awam. But what we do is we provide a lot of interaction and courses, kursus untuk orang awam. So they can come and attend our FACS, FACS. This one is coming. We're going to organize it here in our Department of Emergency, FACS, in June, 21st of June. We will share with you the details. I think it's already in our UKM Hebahan. Students are more than welcome to come. And we will bring, as usual, our live stakes. Okay? All right. Okay? So any other questions? Okay, kalau tak ada, kita go to our... Thank you so much, Docs and okay, for their very interesting presentation. So we go for our quiz.